The next case, we have a 32-year-old male who has an ulcer in the left foot. He is suffering from type 1 diabetes mellitus and has been on insulin for past 12 years. His fasting blood sugar today is 401, and this patient is posted for left diabetic foot debridement. The case shall proceed under left adductor canal block and popliteal block under USG guidance, demonstrated by Dr. Gopal.
Yeah, good morning, Bala, and good morning once again to all those seated in the auditorium. As my colleague just announced, his fasting blood sugar is 401, and this being a sort of an emergency, it is quite a smelly wound. So unless we achieve some sort of a source control, his sugars are definitely not going to be controlled. So what I will be doing for this patient is an adductor canal block to block the saphenous nerve, which will give him analgesia along the medial aspect of the leg beneath the knee joint. And I'll also do a popliteal sciatic, but we will not go live with the popliteal sciatic block because Professor Chan has just demonstrated the popliteal sciatic block to you. So what we will be doing live is the adductor canal block. So as I did earlier, I'm using a high frequency linear probe with a footprint of 38 millimeters. This probe fires between 6 and 13 megahertz. So I'm going to be dipping this into betadine. I've sheeted this probe like I did earlier, and I'll be using betadine solution as an acoustic couplant. And I have set the depth at 4.9 centimeters because this guy's thigh is fairly sizable. And if this is the knee here and this is the superior aspect of the thigh, I'm just going to place it mid-thigh. And the moment I place the probe mid-thigh in short axis, you can see the shadow thrown by the femur on the screen. Can you see the shadow thrown by the femur there?
Yeah, perfectly seen.
Yes.
Well, yeah. Yes.
Now I'm just going to swing the probe medially. And as I swing the probe medially, the muscle that you can see is the vastus medialis muscle. And as I swing it even further, you can see that there is a pulsatile vessel that lies posterior to the vastus, and that pulsatile vessel is the femoral artery. If I release the pressure of the probe, you can see the femoral vein also coming into view there. Now just lateral to that femoral artery would lie your saphenous nerve, and it's not always easy to pick up the saphenous nerve. As we all know, the saphenous nerve is the continuation of the posterior branch of the femoral nerve, and it is purely sensory. And when you do an adductor canal block, in addition to the saphenous nerve, you also get the posterior branch of the obturator nerve, which is almost totally sensory, and you also get the nerve to vastus medialis, which is the only motor branch. So this is a very good block when you are doing knee joint arthroscopies on a daycare basis and you would like to send the patient home in the evening. Because if you do an adductor canal block, there is a good sensory analgesia for the knee joint, and the only muscle that will actually have some palsy is the vastus medialis, whereas the other three of the quadriceps, which is the vastus intermedius, the vastus lateralis, and rectus femoris, will all be spared. And if I just swing the probe even more medially, you can see that triangle shape where the vastus medialis has ended, and then you will see the sartorius muscle take off. And just posterior to the sartorius would lie the adductor longus muscle. If you see the anomaly here, the artery is actually posterior to the vastus medialis and not to the sartorius. This is also known as a subsartorial block, or the adductor canal block, or the Hunter canal block. And if you scan this artery while you go distal, you will see that the femoral artery gives off a genicular artery which supplies the knee joint, and then it dips posteriorly to become the popliteal artery. But this is the area of interest. I've got the artery there in view. The saphenous nerve lies just lateral to the artery, and I'm just going to bring the needle in plane. This is a fairly deep block. You can see that the artery is at a depth of about 4 centimeters, and this person wanted to remain totally awake. My previous patient wanted to be asleep, but this person has refused any sort of sedation. So I'm just going to give a tiny injection. I'm not actually using any local now. I'm just putting the needle in plane, and I will try to go towards the artery.
Can we have a Doppler study once?
Can you just turn on the color, please?
A scout scan to see whether any other small vessels are there on the path of your course of the needle becomes very important to direct the needle.
Yeah, it is a fairly deep vessel, so the Doppler is not actually picking up the color. Okay.
You see the tissue movement here, and
I'm sorry about that. Valirka? You can only see the tissue displacement actually. It's very difficult to pick up the needle.
Could you increase the gain a bit, sir?
Can you see that? I'm just moving the needle. You can see it's close to the artery now. I'm just going even closer. I'm almost there now.
Not been able to visualize it very well.
Needle is very difficult to pick up at this depth.
Even the tip we are not able. Probably some tissue movement.
No, can I just wiggle the needle now?
Yeah, yes, yeah.
See that?
Yeah, it's.
What I'll do is, I'll see if I can put on the MBE. Can you go to page 2? Page 2 on top right. Yeah. This next one.
MBE is multi-beam that's incorporated. So
can you flip it to that other side? Left to right flip. Yes. Now, even with this, it's very steep.
Yeah.
It's very difficult to pick up the needle at this depth. What we will do is, I'll just request my colleague here to make a small injection, and then we will see if we can hydrodissect. Take it off. Take it off. Yeah, please inject. Yeah, please aspirate and inject. Can you see the drug being spread in the vicinity of the artery?
Absolutely, yes. Yeah.
Okay, can you continue to inject? We'll inject about 15.
So we see an anechoic zone just below the vastus medialis muscle?
Yeah, and it is spreading in the vicinity of the artery, Bala.
Yeah, that's right, yes.
Another 5 ml. So that is the idea. If you don't see the artery, if you don't see the nerve, it doesn't matter. All you have to do is place the needle lateral to the artery and inject about 15 mils of local anesthetic. This was not a very ideal case for demonstration because his thigh is actually quite huge, and I'm sorry I could not pick up the needle, but that is the problem with ultrasound guided blocks. As the depth increases, it becomes increasingly difficult to pick up the needle at steeper angles. So what you need to do is, you need to use surrogate markers like short wiggling movements of the needle to deduce the tip, and also use the hydrodissection to deduce where your tip is. So with this, we finished the demonstration of the adductor canal block. I'll proceed to do the popliteal sciatic, but we will not go live with that.
Thank you very much, Dr. Gopal, for demonstrating this.
Thank you, Bal.